Today, we are going to discuss on handling pregnancy losses in your practice with the expert under the aegis of NOVA IVF. This is a webinar brought to you by Bridging Bharat Initiative by Bharat Serums and Vaccines. To start off the program, I would like to introduce Dr. Rohit Gutgutia. He is a medical director for NOVA IVF Fertility East, a chain of fertility clinics in East India and Bangladesh. And his area of interest are fertility and setting up standards. Welcome, Dr. Gutgutia. I would like you to take the proceedings ahead.
Thank you, Anuja. Thank you. Thanks for this kind introduction. So, very happy, good Saturday afternoon to all of you. We are back here on behalf of NOVA IVF Fertility East, presenting the second in our series of educational panel discussions. This is the session that we are having on pregnancy losses in your practice. And today we will be covering this topic. Maybe we'll take some more time, but today we'll be covering this topic in approximately 1.5 hours of your time. Anuja, can I share my screen with you? Right. So the idea is to try and cover the pregnancy loss that we face usually in our practice, along with the panel of experts that we have today with you. And to introduce the panel, it's a pleasure. I have 4 medical doctors who will be guiding me, telling us what's the right thing to do and what's to avoid. They are in no order. Dr. Bashar Mukherjee, as I get it, he is busy on some other webinar. He'll be joining us in a couple of minutes. So Dr. Bashar Banerjee, as we all know, is a leading practitioner in the city of Kolkata and is also associated with the association, FOXY, and is an elected vice president there. Dr. Nidhi Nikunj, Bashar has still not come in. We're waiting for him. Nidhi Nikunj, she's our consultant practitioner in the Ranchi Center. She has been practicing endoscopy, IVF, and obstetrics for more than 10 years now. Welcome, Dr. Nidhi, to this forum.
Yeah, thank you.
Thank you. Dr. Simi Kumari, she is our consultant in Patna. And Simi has been with us for a couple of years now, and her forte is ovarian induction and ovulation induction. So Simi, an extension of welcome to you as well.
Thank you, sir.
And then we have Dr. Shupana Bhattacharya. She is my colleague practitioner here in the Kolkata Center. Shupana, welcome aboard.
Thank you so much. Thank you.
And along with the 4 medical doctors, the real doctor, a PhD in genetics, Dr. Dipanjana Datta, she is also there with us, and she is going to take the difficult questions of genetics and help us understand the confusion that we all have about genetics of miscarriage. If she is also on board, yes, she is. So if we are all ready to go, I think we can start on with our talk show today that is on handling pregnancy losses in your practice. So before I get into the subject directly, we all understand that pregnancy loss is a very, very painful and a sensitive issue. I bring up this quote, which is, there is this unique pain that comes from preparing a place in your heart for a child that never comes. And this is something that we all face in our practice. And sometimes the patient asks questions to which we do not really have any answers to give. Most of the patients want to know why this happened. How can they prevent this in the next time? Why them? And so on and so forth. Most of the time, these questions have very difficult or very vague or complex answers. And to know what to do and what not to do will be now burdening our panel to help us and understand this. My first question, therefore, on this burden of pregnancy losses goes out to Dr. Nidhi. Dr. Nidhi, you've been practicing successfully for the last one decade. My question to you is, how often do you see miscarriages, and what is your way of working with miscarriages, in the sense that how do you counsel your patients when they come across this sad episode of the pregnancy not going through?
Yeah, I mean, this is something that really breaks my heart every time I see a couple, because they come in with a lot of hope and then miscarriages happen. They are pretty common though. So if we look at whatever literature we have, and even in private practice, we see that out of 10, at least 2 couple will have a miscarriage. So that's the usual, incidence of miscarriage. And so this is the first thing I tell them if it is their first miscarriage. So you have to handle them very sensitively. You have to sort of sit with them, give them your time, explain the common causes of early pregnancy miscarriages, and then tell them that with one miscarriage, it's probably the risk of having another one is not that significantly high. But of course, with repeated miscarriages, it just does go up. So yeah, so like you put up the slide, 1 in 4 pregnancies end in a miscarriage. And then I try to take them through what is the normal cause. And so, right, so there is this slide, which again says that pregnancies may be lost anytime between fertilization and implantation. And this occurs in 30% of pregnancies, 30% prior to implantation, 30% following implantation, and then 10% are miscarriages. So what we see in our practice are miscarriages. Yeah.
No, my question was a little more specific here in the sense that how many of your patients, let's say you're saying 1 in 4 or 1 in 5 in your pregnancies do end up in miscarriages. How often do they come up with let's say a healthy pregnancy? You've told them it's a good pregnancy, and then suddenly you realize they're not carrying through, it's a miscarriage, or the pregnancy losses happen. How often do you see this on a practice basis? Let's say in a month, how many times do you encounter such scenarios?
So I guess you're asking me once there's a fetal heart rate and then it disappears.
Correct.
Is that your question?
Yeah.
Yeah. So I guess out of I don't see that very often. Probably out of 10 patients, 1 would have that kind of a miscarriage.
Okay.
That's what I see. Yeah.
So how many times do you face this in a month? Maybe 3-4 times? Is that it?
Yeah, that's about it. Yes. Okay. So it depends on your practice, doesn't it?
Absolutely. So people who are like busy practitioners, busy obstetricians, they have this event happening maybe once in a week or once in 10 days where they are confronted with this situation where there's a pregnancy that has unexpectedly failed to grow. Dr. Shuparna, this is a basic slide, and we all know what is a threatened miscarriage and what is a septic and what is an inevitable miscarriage. You being a majorly ART practitioner, do you see a similar kind of an event happening in your practice, or do you think that in your practice maybe the incidence of miscarriage is a little higher? Or is there a different trend in the sense that maybe the threatens are more or miss are more? What kind of a practice trend that you see in your practice?
To be honest and to begin with, since being totally into the ART practice, we come across a biochemical pregnancy loss that is also there in our practice. And
can you just explain to us, because I always try and make these conversations maybe not very basic, but very, very understandable. So would you like to explain what is a biochemical pregnancy for all of us?
Yes, that is usually when we are saying in the ART practices, and mostly it is the IVF practice, what I'm meaning, where you go for an analysis of a blood test and you measure the beta HCG value in the blood, and where the levels more than say 5 they are saying is positive, but then yes, something more than 18 to 20 is a good biochemical result. 2 results in a days apart, say a few days apart, you see a rising titer that you can explain it as a pregnancy which is losing, or the titer is falling, then you can identify them as a biochemical pregnancy loss. And not a really good rising titer of beta HCG in the blood, you can identify them as a biochemical pregnancy loss. And some pregnancies not reaching up to the ultrasonography stage, disappearing before that, these are the biochemical pregnancy loss. Or you come across an early pregnancy loss where you get a ultrasonographic marker only up till the gestational stage. Correct.
So this is more frequent in ART practice, would you say?
Yes, yes, it is more frequent in the ART stage. Why? Because the surveillance in ART is much more than the obstetric practice. The obstetricians usually get their patients, or they come across these patients only when they've missed a period. That is somewhat 5 weeks into the pregnancy. But here we estimate some, say after a blastocyst transfer, we estimate the blood test, say 10 days after a blastocyst transfer, so which we are very early in diagnosing these type of pregnancies.
So that was really my intention, to kind of differentiate between a pregnancy loss that's sensible to us as ART practitioners much earlier than maybe an obstetrician, because they would see patients after they have missed a period, so very much after the sac has formed and maybe the heartbeat has appeared. So this is what was the intention. In both of your practice, both Nidhi and Dr. Shuparna, the question is both for you. How much of a late pregnancy loss is what you're accustomed to? Maybe a second trimester or a stillbirth? Or is it something that has now thankfully become much lesser with better monitoring?
I think that this is a question Dr. Nidhi might answer better, because I am not into the obstetric practice.
Absolutely.
Usually, when the pregnancies are, or I get referral for these cases, once they are pregnant, when I establish the positive pregnancy, say a 8-week scan, I refer them back to the consultants. And if it is something which is not coming from a discharge, I still outsource these pregnant patients. So in my practice, what I usually find is the early trimester pregnancy losses I do encounter, but the late trimester ones I usually do not come across, because that is something that the obstetrician takes care of.
So, okay. So, Dr. Nidhi, do you still see late pregnancy losses or stillbirths in your practice, or that's thankfully become a rarity?
So when you say late pregnancy loss, are we talking about the third trimester?
Second trimester, third trimester losses.
No, it has, we can't do much about the second trimester losses. I do still see them. And especially with IVF, I don't know, somehow we tend to see second trimester losses. And more so in twins. But otherwise, if you talk about singleton pregnancies, not so many in the second trimester. In the third trimester, if the patient is under regular surveillance, we are able to pick up, growth restrictions and the blood supplies if they are altered. And so the number of stillbirths and the late pregnancy losses are much less, thankfully. Yes. But
I would also like to put in here that maybe the advent of fetal medicine has made life a lot easier for the obstetricians in terms of detecting all this before.
Oh, absolutely.
Absolutely.
Especially with the first trimester screening and the risk, for preeclampsia and who to start on low dose aspirin and stuff. So with fetal medicine, we are being helped with that a lot. And we know we are alert whom to look after more carefully. So that has made a lot of difference.
So one miscarriage is bad. If you have multiple miscarriages, then that's like super bad. Dr. Sisimi, how often is...
Rohit, can I come in once? Rohit,
yeah, sure.
Rohit, this was a question to you, about the biochemical losses, which was discussed by Dr. Nidhi and Dr. Suparna. How significant are biochemical losses, pregnancy losses? Like in an obstetrician, we do see them. We have a faint pregnancy test, which is positive the first day and then negative the next day, and you have the bleeding after that. So that's without checking the levels. But how, are they significant in the long run? If you have a biochemical pregnancy test, a pregnancy, would that mean anything different in a case of subfertility, the things which you manage?
Dr. Shuparna, would you like to take that question?
Yes, Dr. Bashab, it definitely holds a point. You have to be very alert, and you have to be very thorough with the patient. And keeping in mind the reasons of the biochemical losses, you have to plan her next pregnancy. Fortunately, the next conception is much better in cases of they have studies which have said that the next conceptions are better and you tend to succeed more. But yes, keeping in mind the causes for the biochemical, you have to investigate them and plan them better.
No, I need two questions here. Like the way we counsel the patients in the clinic, one, we say that biochemical loss is something which is not a good pregnancy. It never was a good pregnancy. It's not something which you could take home. And so it's gone, which was not good. That's number one. That's one way of looking at it. And the other way is at least you became pregnant, so you could become pregnant again. So which one would be the right approach when you're talking to a patient from an obstetric point of view? No, I'm really asking it.
No, Dr. Bashab, yeah. You have answered both the questions yourself fully. First, yes, you were pregnant, so that is a sad event that it didn't happen. Second, the silver lining, what they are saying of that biochemical pregnancy is that at least the blastocyst hatched and tried to implant into the uterus, so your prospects are good. So that is the silver lining. So both the cases are self-explanatory, as you rightly mentioned.
Thank you. Shubhana, thank you.
Yeah, so Bashab, my take on the whole thing is like what Shubhana said, that in case she does get pregnant through an ART, I can always come back and tell her that my transfer was all right and your womb was all right.
Right.
And I'm so sorry that the embryo did not continue because that was not all right. So next time, if the embryo is all right, everything is going to be all right. So that's the kind of language that we use.
Dr. Bashub,
thank you, Bashubha, for joining in. Yeah.
Rohit, I might just add few. The 5 factors which usually we counsel them. One is that the embryo was not good. Second, your endometrium might not be receptive. Third, you might have there might be some paternal factors in it. Fourth, the oocyte might be bad if you're an elderly lady. And fifth is you might be in stress. Stress does play a role in case of biochemical pregnancies.
I would just, barge in this conversation also, because if it is a biochemical pregnancy and it's a repeated biochemical pregnancy, sometimes there are very well established chromosomal factors as well.
Yes.
So as Dr. Shuparna said over here, the oocyte may be bad, the sperm might be bad. Sometimes itself the embryo might have instability. So maybe not just one biochemical pregnancy, but if there are more than one biochemical pregnancies, then maybe a couple karyotype is not a bad idea to start with.
Thank you, Dipanjana.
So Rohit, again jumping in, I think we're not going away from biochemical losses, but just tell me in a non-ART setup, when would you tell a woman to do a pregnancy test? How many days after she's missed a period to not miss a biochemical loss, if you really want to say it that way? Because we're not doing a serum beta HCG, we're doing a urine pregnancy test, you're doing it at home. So what would be your optimum time to check it so that you don't miss it and it's not considered as a delayed period? You understand what I mean?
Yeah, so basically post-ovulation, the fertilization and the implantation takes 5-6 days later. And it will reflect in your blood and also in the urine 9 days later. So the earliest you could check is around 25 days in a regular standard cycle. But 30 days is a good 28 days is a good point to check because the line shows up nicely. But to put a point here, we do not trust the kits that much because a couple of days prior to she is expecting her menses, the kit might come out to be falsely positive. So which is why if we sense any kind of an issue, usually through an ultrasound or through a blood test, we would like to correlate. So that's the way we practice in our setups. But as you said, in your practice, maybe a UPT is a good tool to find out whether she is sitting on a biochemical.
Yeah, but my question here is, sorry, I'm barging, but my question is why would we want to test for a biochemical pregnancy in a woman in an obstetric practice? Because, does it make sense? It'll just add to her burden. If it's, unless she's had repeated miscarriages.
No, there are issues. There are patients who are anxious and they would like to know. But in fact, that is the good cue that I was looking for, Dr. Dipanjana. You talked about multiple miscarriages, and that's been a good point for you to go for, let's say, the karyotyping and other chromosomal studies. My question to you would be, roughly, in the sense that we all kind of are very nervous about dealing with the genetics of miscarriages. My question to you would be, how would you take care of a single pregnancy loss if you were to refer that patient to you, or somebody with a multiple pregnancy loss? What is the role that you see for a POC karyotyping, a parental karyotyping? Where are we in 2020 regards to cutting edge genetic counseling for a miscarrying couple?
Thank you, sir. A lot of questions. I'll just break it down. The first question which I would take is that when we are looking for factors that we are building up on the RPL, I just so if you can go back a few more slides, basically, if it is just one pregnancy loss, if somebody refers them to me, if sir refers them to me, normally I would just counsel them for the possible factors that can cause a miscarriage. The possible factors being that it can be, it might not be a genetic factor, it might be something else, like it might be an anatomical factor, it might be thrombophilia factor, it might be, yes sir. So this particular slide, so initial one miscarriage, if there is nothing indicated clinically, like if it's an early miscarriage, we normally just counsel them for the reasons for miscarriage, give them the options that see these are the tests which we normally do after a second miscarriage. But if you are too anxious, or if it is a couple who has really like is conceiving at a really high advanced maternal age, or a couple who has some history, like we definitely take a family history over here, a 3-generation family history, and see that there's repetitive miscarriages in the family as well, then we would probably ask them to go for the basic investigations. But normally, miscarriage, if nothing is indicated, nothing is done genetically. If it is 2 miscarriages, and let me clarify over here, the 2 miscarriage has to be intrauterine. We don't consider an ectopic loss as a loss. So here 2 miscarriages has to be an intrauterine loss, and once that is
So,
there,
would you consider
then
a biochemical pregency in this?
yes, a biochemical pregnancy, yes, but ectopic pregnancy is a no. So the other factors I'm sure will be covered. I'll stick to genetics over here. So after the second miscarriage, if we are looking at something, then we would our first round of test, there is a ESHRE guideline over there, which says that we have to this particular guideline is there, and it specifies that what we are supposed to screen. So the initial level would be take your family history and do your karyotype studies in the couple, do a sperm DNA fragmentation, see what comes up over there. Also, at the same time, if the clinician has not already done, then we can proceed for hereditary thrombophilia testing or
We'll
the
be covering that
anti-lupus.
in the course of the discussions, but
Yeah,
basically
so
genetics wise.
so genetics wise, a couple karyotype is my first line. But say, for example, a couple has been referred to me with more than 2 pregnancy losses, and I have a normal karyotype. In such a scenario, then I need to again look back at the family history and then see whether there are other genes which are playing into the role. Now, I'll come to the genetic part a bit, the screening of genes a bit later. But if I just stick on to the karyotype part, what are my expectations and what I can get is what first I'll counsel. So we explained that there are 46 chromosomes and they are in pairs, but sometimes what we can get in couples are these balanced translocations. So if you can just go back a few slides. Yeah. So, yes. So, yes, this particular slide, which sort of, describes a balanced translocation, which has a chromosome in blue and a chromosome in pink. What happens is the number, see, there are 2 chromosomes on the left side as well as 2 chromosomes on the right side, but structurally they are different because a part of the blue chromosome has broken and come back to the other chromosome, and the part of the pink chromosome has broken and come back to the other blue chromosome. So nothing is lost or nothing is gained. But when an embryo is forming, sir, if you can go to the next slide, the embryo is forming, let's say, for example, a parent 2 in this case carries this balanced translocation and is clinically asymptomatic. But when the gametes are forming, sometimes they will carry, they can carry the normal gametes. They can also carry the gametes which are having these balanced translocation. Now, as a result of which, when it comes to possible embryo formation, there will be some chromosomal aneuploidy with unbalanced translocation. If it is an embryo with a balanced translocation, that will grow up to a fetus and that will give a healthy baby. Normal gametes will, of course, give a healthy baby. But there's a possibility of these unbalanced gamete where either you can see over here a gray part is lost or a red part is lost, which will ultimately create an unbalanced situation in the chromosome, leading to those genes totally being lost. As a result, the fetus will not be able to develop. Now, this is something which is very common, and if there is a reciprocal, this kind of a balanced translocation, we would see the couple suffering pregnancy loss repeatedly. And in these cases, early intervention is definitely there. At the same time, sometimes if you look at the karyotypes, you can also find inversions. You can also find satellite chromosomes. You can find karyograms which mention as H plus, H minus, S plus, S minus, these all kinds of things. Now, these are normal polymorphic variants of the chromosomes. Most of them will basically not cause a disease. as say not cause anything like a recurrent pregnancy loss, but we have to take this as what number of chromosomes and what we are looking at, because in some cases, like say for example few chromosomes does have a association with recurrent pregnancy loss, though the association is very low, it's maybe 1.5%, but the association is very low. But in those cases the other factors have to be ruled out, and then it has to be commented that this 1% is where the couple is this 1% includes this couple. Most of the times these are polymorphic variants, and there are other reasons which are combined with this causing the miscarriage. Normally if we are looking at we get very commonly, YQH plus YQH minus, very commonly we get 22 PS plus. These are very common ones. If we are looking at these majorly, if this is a man, then we will get like 22 PS plus. If this is a man, we get subfertility. Maximum times this will cause subfertility, nothing to do with pregnancy loss. But then if you are getting a 22 PS plus or a 16 QH minus or a YQH plus, these sometimes have a association with recurrent pregnancy loss. So in such cases we will actually have to go back and rule out the other factors, and then come back again and then see whether we can we can associate this. Now if we look at the genetics part, so this is the chromosomal part, and the second thing, sir, I would take upon is if it is more than 3 pregnancy. I have seen patients with 9 pregnancy losses, I've seen patients with 16 pregnancy losses, and they are going on in the same way. So if it is more than 3 pregnancy losses, and if it is not a balanced translocation, they are not a carrier, there's no carrier of a balanced translocation, chance of it being a genetic problem increases. Now it's a bit odd, because if the parents, the couples are normal, then how can the fetus be affected? So there are genes which are known as which are fetal to the embryos, and these genes are sometimes in a recessive mode, which means that if I can share one of my slides, I'll just take a bit of time. Yeah. So hello.
Yes.
Yes. So if it's a gene, like if more than 3 pregnancies are there, and if we can see a gene, they can be in a recessive mode in the couple. And in such cases what happens is that, say the couple is asymptomatic but carries the bad gene along with the good gene. So there is a chance in the fetus that the bad gene can come a number of times, and it's not just 25%. We see that it's more than 25%, though theoretically it's 25%. But then there are certain congenital muscular dystrophy, certain congenital other diseases like which are hydrolitholas fetus. So these kind of genes are there, which also causes genetic problems. Also, there are thrombophilia factors, hereditary thrombophilia factors, which are not picked up in your basic testing. Like in your basic testing, probably you have done a protein S, protein C, and you have done a factor 5, but this is not picked up. There are genes like HR gene. HRG, there's a particular gene which is called HRG. Whatever test you do, it will not get picked up. But genetic testing will pick this up. For HRG genes, this is extremely dangerous, because even if you use a donor egg, this lady will not be able to get pregnant, and it will result in a pregnancy loss. So we do see these kind of cases, and so in these cases, if it's more than 3, and if there is a family history, then a genetic testing, a exome screening is very essential. Now sometimes what happens is that in these cases it actually gives the direction to the patients as to what management we can do further. Second, sir said about lastly sir said about the POCs. Now in the POC, when we see, you have to understand that if this POC is about 12 weeks, there is if we do just a karyotype or just a fish, sometimes we might be missing a lot of things. The reason being, the POC if it's an aneuploidy, your karyotype will be able to get it. But something that hasn't grown inside a mother's womb might not actually grow in the culture itself. The chances of that failing in culture is very high. So you might do the test, but then you might not get a report. So in such cases, it's better to go for a molecular testing. And when we say a molecular testing, we mean there are different level of tests like karyotype bobs. There is also QF-PCR testing. There is also a microarray. These also test the chromosomes, but they test it in a way which has higher resolution. So the micro deletions and micro duplications with the aneuploidies are also noted. So this gives us more information than just doing a FISH, where we get information only on 13, 18, and 21. Maximum times you will see, if it is a POC, the maximum times we see a trisomy 16 or we see a trisomy 9. This you will miss if you are doing a FISH. Karyotype will pick it up, but culture might fail if it is an early POC. So in such cases, it's very important that you go ahead and you do a molecular test rather than a cytological test, because somewhere you are getting more information. Now, say for example, in POC, you got a positive test. So how will you manage that would depend on what we are getting in the POC. So that might require additional testing, that might not require additional testing. So these are the few points. And sometimes the fetus, I'm sure all of you have also encountered molar pregnancies also. So those also have a genetic background, and those also need to be investigated from time to time, looking at the family history. So I hope I answered all of sir's questions.
Thank you for that exhaustive review. See, I got logged out. Sorry for the vagaries. So I got logged out for some time. Thank you, Dr. Dipanjana. Does my panel have any questions to put to Dr. Dipanjana? Then we can go on to the next.
I have questions, Rohit.
Please,
so,
Dr.
Dipanjana, like from an obstetrician point of view, what we normally ask for is karyotyping, and that's what we generally used to. You either ask for POC, products of conception karyotyping, or parental karyotyping. So that's where usually you stick to, and that's what usually do. We understand the FISH technique. That's about all that we understand. But anything beyond that, to ask for what you were saying at the molecular level, genetic. So what are the tests do we ask for? Are they all available in India, in Calcutta? Like, what are the ones? What do you really? What should be asking for? What would be prescribing in the test for it to be done?
My first line for the couple, firstly, sir, all of these tests are given by multiple vendors in Calcutta itself. So everything is available. Second of all, sir, the first line of test in the couple would always be a karyotype, because balanced translocation can never be picked up through any other method. So my first line for couples would be definitely a karyotype. But for POC, sir, my first line of test would be either a microarray, it's called a chromosomal microarray, or sir, it would be a QF-PCR, or it would be a karyotype bob. Any of these three, which three different companies provide. Microarray, all companies provide. The karyotype bob is provided by one particular company, and QF-PCR is right now being provided by one particular company. So any of these will give you a better report than just doing a karyotype, because maximum times you will see in karyotype you might get a report saying the culture has failed. So in such cases, it's better for a molecular testing, plus it gives you a better resolution.
So Dr. Dipanjana, if I might just ask, array CGH, because I was just reading the guidelines,
yes,
and they say array CGH. Is that same as microarray? Is that?
Yes, ma'am. Actually, array CGH has also now sort of revamped. Should I say, array CGH was it's basically how the technology is being used now. Array CGH is where the probes are hybridized by oligonucleotide probes. That's called array CGH.
That's all Greek to most of us. That's all Greek to most of us.
I think one thing, Rohit, which is important, which we'll bring in here. What are the clinical significance of the POC
Absolutely.
karyotyping?
Absolutely.
The
Absolutely.
clinical significance,
So
like we get something, we get it's abnormal. So what? What do we do?
Nidhi ma'am, I will send you the difference between RACGS and CMA a bit later.
So,
But yeah,
thanks.
just to answer Dr. Bashub and Dr. Rohit over here, it is that clinically, sir, if normally the trisomy mostly the POC mostly has a trisomy 16 or a trisomy 9, then we can actually predict the recurrence risk, and sometimes we can also tell the couple that whether they should be going for other other methods of pregnancy rather than naturally trying. Because if we see a deletion or a duplication which is in the POC, we might know that it is causing some kind of embryo aneuploidy, while the couple itself has normal karyotype. This sometimes happens due to a condition called gonadal mosaicism. So if we are testing the blood has normal chromosomes, there's nothing over there. We are unable to test the sperm cells, the gametes actually, or the eggs. But the problem might be there. This is especially true if you have a family who has a polycystic ovary, or if you have a person who has high DNA fragmentation. So these kind of couples, you can actually guide them as to what to do in their next pregnancy. Sometimes trisomy 16, if we see everything is fine, then it's just you can actually give a closure to the family saying that this was just one of a cause. Your next pregnancy is going to be there's no risk associated, so just plan your ex pregnancy without stress. So this kind of inputs you can actually put to your client, but like your family, because most of them will be looking for a closure, that why did this happen. The why gets answered, sir.
Okay, I think we'll take it here itself. Thank you, Dr. Dipanjana, for your nice exposition on about genetics and how we handle it in our practice. We'll move on to the other sections. Dr. Shimi has been waiting for quite some time, so this is a question that I throw to her. What, according to her, are the causes, and how does she explain it to her patients? What, according to her, the causes of miscarriage, whether it's a individual, one single miscarriage or multiple miscarriages happening in the same patient? Dr. Simi.
Thank you, sir. Actually, for the miscarriages, age is a major factor. When woman is more than 35 years of age, the chance of miscarriages increases. Along with the age of male partner too. Other factors are genetic, autoimmune diseases, infection, and so many are unexplained too.
Right. So as she pointed out correctly, that maybe age is a big factor, and like what we've been understanding through ART as well, is that with age, we realize that most of the oocyte quality and also the sperm quality becomes compromised. And when they lead to gametes which are not healthy, then we have unhealthy embryos, and then they do not continue for long. So that may be one of the large group of miscarriages that happens in our population. So genetic, paternal, autoimmune, and uterine anomalies is mostly what it is. Yes. Bashubda, in your practice, how do you handle people? How do you diagnose uterine anomalies? How do you handle them? How often do you offer a cerclage to them? What's your way of handling anatomical issues?
Rohit, so for anatomical issues is something which you check a little later in the list. So yes, you would like to have a transvaginal sonography, a very basic one, but not always a 3D one, which they really sometimes recommend to see an uterine defect. But it also depends on at which point of time the miscarriages are taking place. So if it's within 12 weeks, that will not always be coming in mind. Between 12 to 28, yes, uterine factors is what you will be rushing for. You will be having a 3D TVS, asked for a 3D TVS, or possibly an SIS, or possibly an MRI, some sort of a imaging of the uterus to see if there is an anatomical defect to be taken care of. If there
how often would you recommend a SIS or a 3D? Is it like commonly practiced, or is it?
It's not commonly practiced. It will only be if you're suspecting, which will not be unless it's a mid-trimester. Because if it's an early trimester, that's the last thing which you will be thinking. You won't be thinking of initially. So uterine anomalies usually for second trimester miscarriages. Otherwise, in first trimester, unless beyond a normal TVS, you really won't be doing anything. If a TVS throws up some suspicion, then you try to look at it more closely, and then you ask for either a 3D TVS or a SIS or a MRI, something to have a more clear visualization, but not otherwise.
Have you integrated hysteroscopy as a routine practice for these mid-trimester miscarriages, or is it again reserved for some specific couples?
I have not, personally, I have not integrated hysteroscopy as a routine for evaluation. Hysteroscopy would be coming in after imaging points out to some direction, which could be a hysterolaparoscopy too, because if it's some sort of a uterine anomaly which has to be taken care of, or it is the diagnosis is elusive, where we cannot really make out through a imaging technique of different kinds, then we would like to do a hysteroscopy to confirm and possibly correct at the same time if possible. But it's not a routine feature for a diagnosis. It's only if imaging fails or imaging confuses or imaging directs us to do something specific.
And a comment on cerclage. Are you still practicing it? Do you have some indicated cases where you put a cerclage?
Just very recently, we lost a patient where had a 2.7 centimeter cervix during the anomaly scan. And I was just fingers crossed, but she had previous 2 miscarriages. Those were early trimester. I wasn't sure whether that would be the right place to put a cerclage. The last cerclage we put was many months ago, and usually it's not a very common thing in our practice. It's very again, though the biggest risk factor is a previous miscarriage, or a preterm labor case. But cerclage would be reserved for very few people because we have much better treatment than that, and it's not proven in most of our studies to be tremendously useful. So cerclage is not a very common practice in my practice.
Thank you, Bashubda. The evidence also points similarly to maybe not so much of an evidence that prophylactic cerclage reduces the risk of pregnancy. Dr. Nidhi with us. Dr. Nidhi is a very scalpel-friendly person. She is a big-time endoscopist. So how much of a role does she see for correction of uterine anomalies per se in her practice? And what is her practical experience versus the evidence story here?
Yeah, am I? Yeah, I'm not muted.
Yeah, you're audible. Yes.
Yeah, I'm audible. Well, you call me scalpel friendly, but I tend to think that I am reasonable with my scalpel. So as far as uterine surgeries go, the most common thing that I come across are uterine septum. I'm surprised, especially since I've been in IVF, the number of anomalies that I see have gone up. I see more of them now.
We see a lot of polyps. We see a lot of polyps in our
We see a lot of polyps, but it's quite surprising that small polyps they don't do much. So if you ask me, I don't always handle them.
True.
But if they are big, then yes, I tend to cut them with the help of scissors. And the lesser damage we do, the better. So I do not like to use diathermy on those polyps. Unlike the resectoscope, it's better to use scissors. As far as septa go, if it is an arcuate uterus, I wouldn't do anything. But if it is a deep septum, I tend to, like Dr. Basab said, that if there is an imaging which suggests that there might be something in the uterus, so if it is a septum and it is a deep septum, then I would cut it, yes. And but less than 1 centimeter, I don't think, that's not something I do. And the personal experience is that they do well without these surgeries as well. But if
Which is again a very, very fair stand, I think. Be very cautious while using the scalpel, as they say. So yes, I would agree with you here. Dr. Suparna, I'll come back to my favorite theme of ART and recurrent miscarriages. Are they different in ART practices? So my question to you basically is, how do you see the anatomy defects and other issues? We are mostly correcting them before we start off the cycle itself. But how often do you see the use of surgery for such patients?
As you correctly pointed out, when the patients come to us for ART, they have lots and lots of expectations and too much is at stake for them. So before proceeding into ART, we do a detailed investigation, whatever is required, which is usually by transvaginal sonography. In most cases, 3D does good for us. But in spite of proceeding with a normal uterine anatomy, if my patient still ends up with a failure or I find something disturbing the endometrium, like Nidhi said, polyps is something we encounter very frequently. Not only single polyps, but at times we find multiple polypoidal type of an endometrium. if I'm very sure of my embryo and if I'm finding the embryos of a very good quality, grade A and all, but still the patient has come back with thing, yes, I tend to use, or what we generally tend to use is we go for a saline infusion sonohistography to see the condition of the uterus. If you are satisfied with the dilation of the uterine cavity when you fill it with saline, and we see if there is any defect in it, then we leave it up to that. But if I'm not happy with a saline infusion and I find some defect which needs to be corrected, like a polyp or which is obstructing the cavity in any way, then I outsource them for hysteroscopy myself.
Rohit, can I come in here, Rohit?
Sure.
So this is some of the things which we see in laparoscopy, hysteroscopy, which we used to do more extensively before for subfertility, about cervical canal problems. Like cervical can either difficult dilatation or ridges in the cervical canal or some problem to manipulate the dilator during the hysteroscopy. So there, but the uterus is all right. There's no other anomaly. There's no other things. So I'm sure you'll be seeing them during your IUI procedures. Some IUI catheters won't go and all. How do they fare in ART? Is that a section of people who has been studied? Do you know about something? So no any apparent cervical anomaly, but just that the canal is crooked, either it's going in some direction or it's a very difficult dilatation. Would you like to, Suparna would like to highlight? I'm not sure. I would like to learn from you guys about what, is it something which, where the success is less, or is there some problem?
Dr. Bashub, it is mutual. We'd like to learn from you as well. So regarding our practice, regarding the IUIs and IVFs, in case of IVF transfers, what we usually do is a mock embryo transfer is always and always done. So we actually know what kind of cervix we are actually dealing with. And with the catheters nowadays, we are in most cases, maybe one or two such odd cases where we do encounter these sort of services, but otherwise with our mock ETs, we more or less map our transfers. In cases of an IUI where it is difficult to negotiate, usually what we prefer in our clinics is we usually prefer doing it under ultrasonography guidance. That helps us all the more to negotiate the catheters much, much better.
To just add a point here, Bashubda, these catheters nowadays are memory catheters. They have Teflon along with the plastic that's there. So they can be bent in whatever shape that you want to. And that particular catheter can actually be taped to the patient's file so that the same shape can be achieved while we are doing the actual transfer. So that's what we do in mock transfers. So there are two things that as a practitioner we don't understand much. One is genetics, and thank you Dipanjana again for helping us out there. The other thing is the APS or the antibodies syndrome and all that. So before this panel started, I'd asked Dr. Bashub Mukherjee to help us through with how to really handle APS or antiphospholipid antibody and recurrent miscarriages. I actually haven't seen much of it in my practice. I don't know whether it's the same with others also. So how often do you diagnose? What all you do, not do? And will you please take us through the APS part of miscarriages, please?
Yeah. So Rohit, I think the APS conundrum is something which not only you, I think most of the world is still dealing with, and still a lot of research is being done and still will be done. And the final word, I'm sure, is not being told, and it has not been told, and it will not be told in the near future. So there's a lot of work still to be done and is being done on APS, and the research is evolving. So among APS, what you know is by now is that something which is very clear from our understanding is that for a definition of APS, you need the lab criteria. You have clinical criteria also there. And unless you have lab criteria, which is positive and repeated in 6 weeks apart, you can't actually clinically label somebody as APS or antiphospholipid antibody. And we're talking about the acquired antiphospholipid antibody syndrome. So we need to do the lupus anticoagulant, anticardiolipin antibody, and beta-2 microglobin to get an idea about what exactly you're dealing with. And if it's positive once, it doesn't mean that you have, it has to be positive again. But in clinical practice, generally we see that there's extensive use of aspirin, low-dose aspirin, extensive use of low molecular weight heparin far beyond the diagnosis of APS. And now the question is, if you're using it so much, where are you using it and when are you using it? The question is, if there's any miscarriage after the, let's say 10 weeks, where you're having a live embryo, which is one of the clinical criteria, irrespective of the lab criteria, I think most of the obstetricians would be very happy or would be reasonably pleased to use low molecular weight heparin for a live embryo demise after 10 weeks. I think a lot of people would definitely consider low molecular weight heparin, though there is little evidence to back its use without a classic diagnosis of APS. So I think a lot of our practice in generally, like even the progestogens that you soak the IVF patients with once they are done with the embryo transfer, are not always fully evidence-backed.
Absolutely.
So
Absolutely.
I think so there is a lot of low molecular weight heparin use all over the place for idiopathic recurrent pregnancy loss. And there have been many trials over the last 5-6 years in Europe, all showing that they do not make any difference in the live birth rate. But nobody does not want to take a chance. In the private sector, people are overcautious. Doctors are doctors are obliging, patients are willing, and the pharma company laugh their way to the banks. And so there is a large amount of use of low molecular weight heparin. Unfortunately, a lot of that is evidence-based. But a lot of people, to do a study or really to compare, is I think a lot of people will not take a chance to do a trial where you don't use it, because a lot of people have a pleasant feeling that if you're giving it, it is making a difference.
You are in control. You are in control.
Because a lot of people do see that if you're giving it, you have a good result in the end. But you don't. But they don't have the means. You can't do without it, sort of a thing. About low dose aspirin, I think there's a huge amount of literature on low dose aspirin beyond the APS feature. So there's in an FGR, there's a big role of low dose aspirin. Previous pre-eclampsia or HDP, now they say hypertensive disorder pregnancy, there's a big role of low dose aspirin. So low dose aspirin is coming in multiple ways. There's a very nice guideline with a huge list of conditions in which low dose aspirin can be given. About the high dose aspirin of the 150 micrograms, it's mainly for previous hypertensive disorders or previous FGR or previous stillbirth. But otherwise, the 75 micrograms, I think, is generally what a lot of people still now accept. So so APS, as you mentioned, diagnosed APS, classical low molecular weight heparin from the time the fetal heart rate is seen to after delivery till you have crossed the time of thromboprophylaxis after that. And if it is congenital, then that's a different story totally. If it's a previous history of thrombosis, that's a difficult story totally. You need to give her a low molecular weight heparin from the beginning till the end. So
I have a couple of follow-up questions on this.
Yeah.
One is the LMWH that you said. Do you have a preference for dalteparin or enoxaparin or any other product, or do you still go with the old-fashioned heparin? And if yes, then what is your choice and why?
So the old-fashioned heparin, because of the inconvenience, is more or less out, and most of us are sticking to low molecular weight heparin. Enoxaparin is personally my choice, but again, it differs. It depends on what's available. But enoxaparin of a dose of, again, you ideally you should measure the body weight, and you should ideally taper it to the body weight. But when you're giving something which is doubtful, dubious efficacy, then you usually don't exactly cater to the actual dose which you need to give. You're giving usually a 40, or in some overweight women, 60 international units is what you usually stick with and continue giving it for a reasonable amount of time. So enoxaparin is personally my choice. We haven't gone into the details of looking into each type of low molecular weight heparin to see which is better, because we haven't got into that study or haven't got into that detail. But this is how, Rohit, we usually use it.
So now I'll move into more controversial areas. Basically, I feel that as practitioners, we are obliged to give an answer to the patient, and somehow we can tend to overdo things, and therefore looking for antibodies is one such area. We ask for homocysteine, we ask for prothrombin gene mutation, we ask for the MTHFR gene mutation, even protein C, protein S, which was being pointed out by Dr. Nidhi. I throw this question open to the panel. What is your view? Which all tests should be rationally be done, and which should be done in specific situations? Like for me, I am a very biased person as far as the anti-thyroid antibodies are concerned. So I'll start with Bashabda. just because you are alphabetically the first, but what is your set of antibodies that you like to check for, including anti-sperm antibodies, and do you see any reason or rationale behind it?
So antithyroid, as you rightly said, that would be my choice too first. So antithyroid antibodies would be, so the TPO is something which you would be asking for. The other way,
in case that's raised, do you do something about it, or you just kind of counsel them about the fact that that may be one of the reasons?
I think counseling would be the main thing. Subclinical hypothyroidism, if you know, you have to treat it. So that's about it. If necessary, to refer to an endocrinologist, maybe sometimes, but more or less you try to handle it yourself. I think that would be generally the advice. About the hereditary thrombophilias, which you mentioned, the factor V lead-in mutation, protein C, protein S, though that section is something which we rarely deal with. We hardly deal with. Doesn't normally come that we'll be asking for that battery of tests. Same for hyperhomocystemia. Though we extensively lecture on hyperhomocystemia, we talk about active form of folic acid and the methyl tetrahydrofolate gene reductase and the genetic problems and the high level of genetic variants for which the enzyme is not available, and the cause for giving active folic acid instead of normal folic acid. We don't check for a hyperhomocystemia per se, because most of the folic acid that we offer our patients would be the active form with vitamin B6 and B12. So in case there's a deficiency, you're already catering to it in most of the cases by the medicines which you're giving it. So personally, in my practice, I won't be going much beyond antithyroid, but I love to hear from others.
Yeah, Dr. Nidhi, what's your opinion on this?
I think what I normally do, if my patient has come with recurrent miscarriages, the first thing I would investigate for definitely the antiphospholipid antibodies. But that's, everybody's doing that. The rest of it is the, the homocysteine, the antithyroid, prothrombin gene mutation that I mentioned to you, and protein S. That is something I would normally test for, yes. But I tend to discuss this with the patient. I do tell them that, this is something that's still controversial. We don't really know how much it helps. And I was surprised because I've had multiple patients with miscarriages, and one couple, they had this protein S deficiency, and I did give them a low molecular weight heparin in their 4th pregnancy. They had lost 3. So that was a live childbirth. But the next time round, the lady didn't want it. And because she was negative for antiphospholipid antibodies, we decided that we wouldn't give it to her that time. And that resulted in the birth of a perfectly healthy baby. So that set me thinking. And so I would test for these, but as far as, I'm quite open to discussing things with my patients. With antithyroid antibodies, if the patient does not have subclinical hypothyroidism, if it is her, second pregnancy, I would probably just counsel again. But with free losses, I think as a feel-good factor, I tend to add 12.5. That's just me. It's probably not evidence-based, but I just feel good about doing that. But I do follow.
This is to remind everyone that this is not a panel discussion on evidence. This is more on practice. So
but I do follow with the TSH and an FT4 to make sure I'm not overdoing it. Because you don't want her to become hyper, or too much of thyroid hormone as well. So,
Dr. Simi, do you have anything to add to this, or do you think your practice is on similar lines?
Actually, in my practice, I keep on doing APLAT, definitely, a test for antiphospholipid syndrome, and thyroid testing with TPO. Rest I'm not used to.
Anytime have you asked for anti-sperm antibodies? They used to be done 20 years back now, but now people have stopped doing it. Have you asked for anti-sperm antibodies in your practice ever?
No, sir.
No. Okay. And Dr. Shuparna, any change of opinion, a different opinion?
No, I agree with more or less what Dr. Bashov and Dr. Nidhi have said. Yes, the antiphospholipid antibodies, lupus, cardiolipin antibodies, in addition to those, the antithyroid antibodies. What I usually try to maintain in case of high TPO antibodies is like to maintain the TSH level around 2.5 for these patients by supplementing levothyroxine for these patients, and make it also Yeah.
No, please go ahead. Please go ahead. Yeah.
Yes, to make it, again, they've said to make it a trimester specific. So if it is in the early trimester, to keep it around 2, and then simultaneously keep increasing for the second trimester and the third trimester. And you keep monitoring that. In case of subclinical hypothyroidism with anti-TPO, yes, again, monitor the T4 level, supplement in case I feel in cases of recurrent miscarriage. But yes, I do keep my TSH level at 2 to 2.5 max for these recurrent pregnancy loss with anti-thyroid antibodies.
I'll come back to you for this little bit of a ART flavor. As Dr. Dipanjana pointed out briefly, something about sperm DFI. This is something that is very unique to the IVF clinics, I would say. We do see a sense of checking the DFI, that is the DNA fragmentation index of sperms, because we do understand that the paternal sperm is also responsible for a poor embryo and therefore a miscarriage. How often do you check for it? Dr. Shupona, would you explain what DFI is all about and how does it help in your practice?
See, male factors are responsible these days for the infertility. Regarding the pregnancy losses also, you have an unknown, you have a group where there is no cause found for the infertility. There, in cases of recurrent pregnancy losses, you tend to check your male partners as well. This basically tells you about the DNA integrity of the sperm. If the DNA integrity is disturbed, if the DFI is high, then these sperms are not capable of producing very good embryos. So once you're testing them, you have to look into the factors which are leading to this. So in the male partners, what you will check is there, besides having any hormonal imbalances or any metabolic disorders, you will more or less look in for the lifestyle factors also. For instance, their weight, whether they are obese or not, whether they are smoking, they have an alcohol. So these all, anything which leads to the oxidative stress in the sperms disturbs the DNA integrity. These are the extrinsic causes, what I have just mentioned regarding alcohol, smoking, obesity, the lifestyle, and there are intrinsic causes as well. So once you've identified the sperm with a high DFI, you can actually work out to help these patients by providing them with different solutions for these problems.
So yes, antioxidant may work for some of them.
The lifestyle modification works. Antioxidants works. If the ejaculation has to be more frequent, because the more semen they get, it reduces the DNA damage and the oxidative stress is less. So these are just simple measures.
Absolutely.
And in case of ART, being ART specialist, we then might instead of the ejaculated sperm, you might use the testicular sperm, yes, where the DNA integrity is much
Rohit, can I come in? I have
Sure, please.
One question I'd like to ask Dr. Suparna is, if DNA fragmentation index, if it's so good, why don't we do it for every person? So like when we're doing a semen analysis, why can't we do a DFI for every person with that? Does it cost too much? And next one question is, the interventions which you said about reducing smoking, reducing alcohol, and reducing weight, I thought we'll be giving them irrespective of whatever their DFI is. So
absolutely.
Clarify with these 2 points. One is whether we do it routinely for everybody. When we're doing a semen analysis, why are we stopping there? Because if DNA fragmentation is that common and that okay, even without a miscarriage, why can't we do an investigation for subfertility? Why can't we add that to our armamentarium? That's number one. And number two, about the intervention, if you have a high DNA fragmented index, you said oxidative stress, which you said is the cause. Often we do give oxidative stress antioxidants to a lot of male partners, and we do give the advice very similar in your lines of decreasing alcohol, smoking, and weight. So what difference does it make, or does it make a big difference if you want to? I need clarification.
Yeah, so to answer your first question regarding advising it for everyone and all, see, again, there is evidence lacking and the studies are lacking. So we really don't have that. Secondly,
there is also this challenge that even the semen analysis is not standardized in most parts of the country, including our city. So because the semen analysis itself is not standardized, going one step ahead and doing a tunnel or a chromatin assay or a halosperm as yet is a logistical nightmare. Maybe with time this will get standardized, but as yet it's a logistical nightmare. And Dr. Shuparna.
Second question is, when we are doing these tests, we are not being able to utilize those sperms for these after doing these tests, which is very, very important. Next, it is an expensive procedure. So your social regard, as in India, this is something which is a big something which we have to take into consideration. And as for these things, yes, for a male partner, when they walk in for subfertility with or without DFI, the lifestyle modifications are something you definitely advise to them. Absolutely. And without going into them, you can always advise them to ejaculate more often to overcome this oxidative stress, like I likely mentioned. If it is an add-on armamentarium in your kitty, in case you want to investigate the patient further.
So I have a question here, if I may ask Dr. Suparna.
Sure.
Yeah, so suppose there is a couple with recurrent miscarriages, and the husband, and they're conceiving naturally, but ending up in miscarriage every time. And we've done a DNA fragmentation, which has come back as positive. So DFI is bad, and we give all the, interventions, you exercise, you antioxidants and stuff. But despite that, the DFI remains high. Now, what is the next step? What would you do? I mean, is it rational? Because in ART cycles, it's easy for us to do a sperm extraction from somewhere where they're less likely to be DNA damage. What about people who are conceiving naturally? What is the next step then?
See, another thing, first thing I would like to know is the age of your patient. So that matters more. Besides that, the lifestyle of the patient is important. You can offer them an ART treatment where you can explain to them that yes, your testicular sperm will be better in case of if you want a conception. If they're not wanting, you just go in with your antioxidants, with your more and more ejaculated sperms. Use those sperms which are more frequently ejaculated, and maybe a lifestyle modification if they really do not want to move into ART.
I will just barge in over here because we had discussed a bit on this earlier. Sometimes these people who have a high DFI and have a defective DFI, these people sometimes have those kind of chromosome satellites or heterochromatinization as well. Number one. Second, there is some sort of an evidence also that, when you're looking at a sperm morphology report, as well as there's a section of motility and number of live sperms and all that. So in that section, sometimes maybe the sperm count is fine, but there might be some problems with the motility as well. And in these cases, there can be, which is very less known, but there are considerable studies which says that there is a AZF factor, though we know this as azoospermia or oligozoospermia factors, but there are increasing evidence which show that along with this AZF, in the AZF region, there is another gene that is present which actually causes these kind of issues, and these people are actually prone to miscarriages. So just a high DFI majorly can be a lifestyle disorder, as you were discussing, and can be due to allied factors, but there can also be a genetic problem also. So if all your measures does not come back as doesn't seem to improve it, then maybe this is something which you can consider, and you can counsel your patients accordingly that way also.
So are you suggesting
I'll get in
Absolutely.
here. We have to kind of keep moving. On a lighter note, I'll just say that we are a practice that's always looking for indications. So even for molar pregnancies, we have now decided ICSI is best because we can inject one sperm into the egg. And similarly, for DFI also, once DFI becomes standard care, we are going to get in and tell people that come for IVF, because then we can select the sperms better. So that's our noble intention, really. To speeden up things a little bit, we know the rest of the reasons for miscarriages, whether it's diabetes or PCOS or hypothyroid or hyperprolactin. We have kind of touched them as well, and this is kind of standard practice. We've all been knowing this. I would like to touch on the real controversial topics. So luteal phase defect, is it still a condition that exists, or now we are past it? Dr. Shuparna, again, we come back to you. What's your opinion on LPD or luteal phase defect as a cause of miscarriage?
See, the studies and the evidence and the ESHRE guidelines, what they've said is LPD cannot be tested because of the different methods which are to be tested. So though that not being there, and they have finally found that this is something, it can cause miscarriages or whatever progesterone you supplement, that is, there is no evidence to that. But this is something which I would like to clearly mention as in case of ART practice, which is absolutely different from a person who has conceived naturally. In a spontaneous conception, you really cannot test these things and you cannot really come with a solution for them. But regarding the ART, when we are going in with gonadotrophins, we are going in with pickups, oocyte retrievals, or we are going in with the frozen transfers. When in our all treatment protocols, we are actually finding that the progesterone needs to be supplemented because one and only reason is that the corpus luteum, which is very, very vital organ, which is a vital functioning organ.
Yeah, so basically in ART, what happens is the corpus luteum is usually not present.
Right.
So which is why in these patients, LPD may exist. Whereas in other patients, we are not very sure whether the egg quality was bad and therefore the corpus luteum was bad and therefore there was a luteal phase defect. So we don't know whether it's a cause or the outcome of that cause. Lifestyle, again, we have briefly covered. Obesity, smoking, alcohol, caffeine is something that we need to avoid. Unexplained infertility. I don't know who will take this. Dr. Nidhi, are you okay to take this and explain what is unexplained? After we have been able to get all the reasons together, what is unexplained infertility? Unexplained.
All right. Yes, I mean, today we are talking about miscarriage. So it's unexplained miscarriage. So like the Royal College says, 50% of RPLs are unexplained. We don't really find a cause. Now, this is saying, could it be a chance? Hang on. The slide,
Sorry.
It threw me off. So normally in unexplained, there is no role of anything empirical. Although sadly, I've noticed that there is a lot of empirical treatment with progesterone, low molecular weight heparin and stuff like that. But the evidence states otherwise. And personally for me, I do not use any of these in unexplained. Just supportive treatment is enough. And because I've been practicing obstetrics for a long time, and wherever I've worked, I've noticed that if after 2 or 3 losses, somehow just with supportive care, and by supportive it means bringing them more frequently to the clinic, doing more frequent ultrasounds, somehow that seems to help, and there is a high chance of getting a healthy pregnancy and a live birth in the next subsequent pregnancy. Sometimes, I think I do tend to add a bit of low molecular, low dose aspirin. It's just something because, that will probably never be tested in these situations.
So basically, I would divide the practitioners into 3 categories. One, who want to put on everything to their patients and see whether it works or not. The second category is who are doubters that there's some kind of an immune effect. So then they are the aspirin, heparin kind of people. And then the third, or the progesterone kind of people. And the third would be the genetics minded, like Dipanjana, who would be sure that the embryo has failed because the embryo has some as yet not diagnosed genetic defect, and therefore the embryo has failed to grow. So this is where the conundrum is. Basically, we are stuck between calling these pregnancy losses as whether it's because of an autoimmune or an immune condition or because of genetic condition. So that's the sense that we are all getting. I would like to, again, come to the controversies, as I said, one by one. Bashubda, in 2020, do we see any role for TORCH, or have we abandoned it completely?
Abandoned for the finding out of cause of recurrent pregnancy loss.
RPL, it is RPL only.
RPL TORCH is gone. The only reason why we need to do TORCH if the woman comes with fever and rash in the first trimester, and you need to know what is happening. So that's only the reason when you do TORCH, but TORCH has no role, or the interpretation of TORCH has no role, according to me, in recurrent pregnancy loss. As Dr. Nidhi said, we still see prescriptions with treatment for toxoplasma and cytomegalovirus, which I think is untoward and unfortunate.
So I should not continue giving rowamycin for IgG positive and all that stuff.
Unfortunate.
Okay, fair enough.
Sad.
Does anybody use this in their practice, in the sense that they find out the period of gestation of the lost pregnancy and then accordingly investigate? Is this practiced by all of us? Like, do we look at the loss of pregnancy? Because in our counseling, we use it very often. If the heartbeat has not appeared, we tend to tell the patient that mostly it is genetic. If the heartbeat has appeared and there's a loss thereafter, it could be either hormonal or autoimmune or immunogenic and so on and so forth. If it is in this late pregnancy losses, it's usually thrombophilic is what we tell our patients. Antiphospholipid, we have done the controversies as well. We do give aspirin. That's the consensus that we have. Heparin is for some patients. Steroids, is anybody giving steroids to the patients? So there's a clear no from all the panelists. Anatomic factors we covered. The cerclage has maybe a limited role and also insufficient evidence to try and see the effect of septum resection in pregnancies to prevent miscarriages. Immunotherapy. So I see this happening a lot more in North India, thankfully, giving LIT, leukocyte injection therapy, or injecting with the paternal cells, or intravenous immunoglobulins, or other such things. Anybody, Dr. Nidhi, Dr. Suparna, Dr. Bashub, do you think you see any role for giving any of these medications to any of the patients?
I don't see this. I've never done it. No.
Even I don't use it in my own practice. I usually do not go for all this.
Okay, so at least in my panel, we are clear. Bashubda?
As we don't use it ourselves, and as the published evidence is not in favor of it, so we would be not in a position to comment would be the right way of.
Absolutely. So
I learn from our North Indian colleagues what they're doing there.
Absolutely. So I have kind of thrown caution to the wind and taken out the snapshot from Facebook where the people are using Bharglobe in many patients of RPL, and they are always successful.
I do see a lot of prescriptions of Bharglobe.
So they are always successful. So this is something, a point of note for all of us. HCG supplementation in threatened miscarriages or in all patients if they had a previous miscarriage. Bashubda, would you like to comment here?
We've stopped a few years ago. Before that, we used to do baby steps of HCG, but no HCG anymore. So no HCG for anything.
Okay.
So not threatened miscarriage, not recurrent miscarriage, not.
Okay. I'd like to point out here that we see prescriptions where HCG has been prescribed to IVF patients as well. You have to remember that most of the transfers these days are frozen transfer, in which case HCG has absolutely no role. So that's something that we have to stop completely. And then the final part of the discussion, the progesterone. So we all tend to use all kinds of progesterone, and that's maybe the competitive practice that we have, or maybe the pressure from the pharmaceutical companies, or maybe the sense of doing something to our patients. One by one, I'll take it from Bashubda onwards. Do you use progesterone? If yes, then you're an oral person or a vaginal person or an injectable person. How often and how much and how long?
So sense of doing something, I think, is very important in your mind. So sense of doing something, and the act of omission and act of commission. You always like to do a commission. You have to do something and fail rather than not do something and fail. I think in gynecology, it works better than the masterly inactivity in obstetrics. So this is a different kind of thing. So the idea would be to give something. The progesterone, which I have been in love with, most of my practice has been dihydrogesterone. And so it's oral progesterone for me, and oral progesterone so from the last 2 decades, from the time I'm practicing, I've been using it for threatened miscarriage, sometimes recurrent miscarriage with less evidence to back it, and but always completed by 12 to 14 weeks, not beyond that.
Thank you. This is a very precise answer. Dr. Nidhi, what's your choice? What's your poison, as they say? And would you agree or differ?
Yeah, well, I agree with him. I agree with Dr. Basab. I don't normally use progesterone in my obstetric patients, but I do use it in threatened miscarriage if there is a heartbeat and the patient is bleeding. That's when I would use it. And again, oral dihydrogesterone. I don't even take it to 12 weeks. I probably take it for, when the episode happens, I give it to them, and then for maybe another 10 days and I stop. But of late, what I've noticed, I mean, I don't do it, but I've noticed that there are a lot of people who are adding progesterone even for low risk pregnancies. So that's something, it's not very nice to see. But the patient is pregnant and progesterone is prescribed. So.
Dr. Simi, you being an ART practitioner, what's your standard progesterone supplementation for recurrent pregnancy losses or miscarriage patients?
Actually, we use.
Yes, please go on. Yeah.
Dydrogesterone by oral, definitely, and sometime micronized progesterone too by vaginal route, and the outcome is same for both.
So you feel both works or doesn't work, but you're equally.
It's what yes, sir, equally.
Fair
The
enough,
effect is
fair enough.
yeah.
Fair enough. Dr. Shuparna, any comments?
Regarding the ART practice and using progesterone, since if it is a stimulated cycles, the corpus luteum not being there, we use progesterones, oral dihydrogesterone after the heartbeat, and vaginal. In case in the ART practice, we often encounter bleeding for vagina. In that case, we use injectables, which works very well. And we continue till 12 weeks, or I continue till 12 weeks, because I just let the placental shift happen. When the placenta is in place and functioning properly, then I slowly taper it off. So I usually go with the vaginal micronized one with oral one. But in case there is bleeding, which we often encounter in the ART practices, then I usually go for the injectables.
And thus Bashabda said that we drown our patients with all kinds of progesterone. Bashabda has to say something.
No, I just want one point. Yeah, the point about fetal heart rate, starting after fetal heart rate seen. So where does that come from? That comes from that if there's a fetal heartbeat seen, means after that the hormone takes over, or should you be, why are we waiting from fetal heart rate to be seen? Because in my clinical practice, I started earlier, and I don't reason, because there's some studies to show that started after fetal heart rate seen. But what is the logic, if I can hear from Nidhi?
So are you asking about dydrogesterone?
Yes, dydrogesterone.
Yeah, it's probably because I what Dipanjana has.
You've got a urine pregnancy that's positive. You've got a UPT positive. Yes. So it's just been 3 days after her missed period. She's trying for and let's say she has a bit of spotting. So would you be giving it that time, or would you be holding on?
I would hold on, because the reason I do it is that we do know that a lot of early pregnancy losses are because of genetic abnormalities in the embryo. So I like to have a heart rate, because that sort of tells me.
But that would happen irrespective, Dr. Nidhi, it would happen irrespective of whether you're giving it or not.
Absolutely.
No,
it will be happening irrespective of whether you're giving it.
Yeah. So it doesn't make sense if there's no heartbeat.
Unnecessary medication, you mean?
Yes, that's what I mean.
Unnecessary medication.
Yes.
I get the point. Yeah.
Okay, I'll come to the rapid fire questions that has come from the audience. We have 15 questions. We'll run them through one by one, and we'll try and take the questions. Whoever wants to answer can raise their hand and take the questions. Question number 1, causes of sudden IUD in a 30 to 32 week pregnancy, comes from Dr. Sushma Rani. Anybody? If nobody raises hand, then I point out. Dr. Nidhi, would you answer this, please?
Sudden IUD in 30. It
can be.
Yeah.
Well, it could be. I mean, is it growth restricted or is it unexplained? I mean,
this is what I have. Sudden IUD, and so most probably it was all going.
Well, I would think of antiphospholipid antibodies then.
Yes, it can be too.
Okay, so diabetes and
diabetes is another point.
IUGR.
IUGR.
Okay.
Yeah.
Please, Dr. Shuparna. Yeah.
Yeah. So see, this pregnancy is actually lost. You call this patient maybe after 6 to 12 weeks.
Yeah. So that's the next question. How to investigate before next pregnancy? This comes in from Dr. Shahanara Chaudhary. Please answer this.
So I think the first would be to do the karyotype of the fetus.
Dr. Shuparna is taking this question.
I wouldn't do.
Dr. Shuparna is taking the question. Yes, Dr. Shuparna.
Yes. So first, the patient, you actually, when she loses this pregnancy, you actually see her after, say, you see her or you counsel her, or you actually meet her as soon as possible. But you actually investigate her, say, maybe 6 to 12 weeks later. You sit and plan out. You see her antenatal chart. You see her different physical characteristics. You see her different, how she was monitored during her early pregnancy, where does she actually stay and how frequent she was with her antenatals. And then maybe plan out her next pregnancy. Tell her not to get pregnant again.
No, the question is, what investigations, very specific question, what investigations would you carry out?
Yes, we will investigate her. The routine ones is for sugars, that is diabetes. You investigate her. Maybe a GTT will do good. You investigate her with the thyroid antibodies. You do the Apla syndrome for her, and rest you do a ultrasound test and of course examination for
Sir, if I also can add to this, I know I bring the genetics angle everywhere, but then sir, sometimes the IUD can also happen due to what we call as a prenatal SMA, which is very common in India. So I wouldn't lose the fetus there. I would definitely ask, even if they don't want to go for full-fledged investigation, I would ask them to store the DNA, come back when they are willing, mentally more stable, and then can discuss at least the other options which can be a bit different than what we normally think about. So there are few indications, like there can be some kind of congenital muscular dystrophy. There are some neuromuscular disorders where we see this kind of prenatal associations, and those can be investigated if the physician feels so.
Fair enough. I'll have the next couple of questions are meant for Dr. Dipanjana itself. Role of any other chromosomal test other than karyotyping? This comes from Dr. Lima Shampa.
Sir, as we had discussed, there are right now depending about the couple, then a karyotype is enough, but sometimes we do need a microarray, but that should be an indication based one, because we don't normally find much of a microarray in the couple itself. But if we are investigating the fetus, or if we are investigating a POC, their role of karyotype is much more compromised. But if we are looking for a chromosomal microarray is there, we can also go for what we call as a QF-PCR.
How do you correct balance translocation? This comes from Dr. Yasmin Akhtar.
The balance translocation cannot be corrected as per se, but we have options like PGS or PGTA as it is newly classified, where we can use an IVF facility of having the embryo, and these embryo can be biopsied at day 5, and the good embryos, which are either balanced or normal, can be implanted, and that can be a good way to approach this. The other way, which is sometimes more cost effective, is to go by gamete donation, like whichever of the partner has it, the gametes can be changed, like either it's an egg or a sperm, and then we can proceed for this also.
So we can go for what is known as a pre-implantation genetic screening and biopsy these embryos and look for structural rearrangements, and then come back and tell us whether this is a healthy or an implantable embryo. Thank you, Dr. Dipanjana. The next question also goes to you, and this is from the respected Dr. Rokeya Begum. Role of Y chromosome microdeletion.
Yes, role of Y chromosome microdeletion, normally it is very well associated with non-obstructive azoospermia or oligozoospermia, but right now it is not in diagnostics, but it's currently in research phase, where if we are associating it with recurrent pregnancy loss, there's another gene called DSX, which is sort of being associated with pregnancy loss as well. Till now, diagnostically, we are only looking at the European andrology markers for Y chromosome, which is again not very suitable for the Indian population, but then we don't have the alternative over here.
So I'll decode it for the people who are still listening it. There is a chromosome, there is a Y chromosome, there is this region in that Y chromosome that is associated with sperm manufacturing, that's divided into a zone A, zone B, and zone C. And when we do a test, we can actually find out whether the genes located in those regions are absent. And that's when we call it a Y chromosome microdeletion. Dr. Dipanjana, you'll have to make it easier for us to understand.
Sorry, sir, I'm sorry.
Next question goes to Dr. Nidhi or to Dr. Simi. Role of uterine natural killer cells, do you check for them? Dr. Rokeya Begum, once again.
No, definitely not. There's no role. Actually, in listening, it is natural killer cell, but there is no evidence that it has any importance in assessment of RPL.
So we are always looking for trying to explain losses. So natural killer cell is a very catchy name for certain cells, which could be identified in the blood or in the local endometrium and may be used as an explanation for failure of pregnancy to grow. But now it's been mostly abandoned. Dr. Nidhi, would you agree?
Yes, absolutely.
Okay. Next question goes to Dr. Bashub. Why not put a cerclage if you see incompetence in USG in the first pregnancy? Why unnecessarily wait for repeated loss? Again, Dr. Rokeya Begum.
Okay, incompetence in the first pregnancy, I think diagnosing it is a problem. So how do you diagnose an incompetent os in a non-pregnant uterus. I think that's where the first problem comes. And I think why will a woman come to you with an incompetent loss? How does the diagnosis come? It will not come by sonography. It will not come. It'll come by an HSG possibly, or an SIS. And now
so there is a related question here. Which is a better image, a hysteroscopy or a TVS or a SIS? That's also a question from Dr. Rokeya.
I think the SIS has recently been in the picture, and it really gives a much more information than the TVS per se. And I think SIS is a very common investigation which a lot of us ask for in a subfertile woman, to get a more idea about where it has the tubal patency, as well as you get an idea about the adnexa very clearly, and the intrauterine anatomy. So I think an SIS, if available, would be my first choice. And otherwise, it would be a TVS after that, a 3D TVS, possibly if you're looking at uterine anomalies, but a normal TVS would do in most of the cases. So that was one. What was the second one? I forgot.
What is your call on cerclage in the first?
Dr. Nidhi, would you like to take that? Yes, Dr. Nidhi.
Yes, I think Dr. Rokeya is asking if you see an incompetent cervix. And now I'm guessing that she is talking about the length of cervix, because that has that has a quite a good predictive value. If the length of cervix is less than 25 mm in the 20-week ultrasound, then there is a possibility that that patient might go in preterm labor or might deliver early.
So would you put a cerclage based on the ultrasound finding?
If it depends on the length again. So if it is less than 25 mm and she's had a history of miscarriage or a loss, then I would definitely put it. But other than that, giving her progesterone and watching her is something that I tend to do. But then we follow with regular TVS to see the length of the cervix. And if it shortens further, I would cerclage, yes.
I just want to ask Dr. Nidhi a question here. Do you ask for a cervical length surveillance for your patients from the first trimester itself?
There is, whether we ask for it or not is irrelevant. Nowadays, the radiologists give us the cervical length anyway. But okay. I do ask them to do a TVS and not comment on an abdominal ultrasound, because that can give you false reports. So, but again, still, I would still only act on the length of the cervix in the, second trimester ultrasound. If it is less than.
As per a recent classification, you could put cerclages on 4 situations. You could be doing it on a basis of history, on the basis of imaging, as Dr. Nidhi said, maybe as a rescue cerclage. So there are different ways you're putting a cerclage, but usually that's not the practice in the first pregnancy. How do you handle a case of unexplained recurrent pregnancy loss? This is a question I throw to Dr. Suparna, and this comes from our Dr. Isha Sharma.
Unexplained pregnancy losses after you.
I need the answers quickly now because we're closing out. Is it antibodies? What is that you'll be focusing on?
What did I missed out on the first thing?
Unexplained recurrent pregnancy loss. How would you handle that patient?
After investigating her and looking into it, if we still find no cause for her loss, I would like to use low molecular weight heparins and aspirin for her for the future pregnancy, just to be on the safer side. There's no evidence as such, but yes, just to be on the safer side.
Also, sir, genetics.
I would.
And genetics.
I think I would hold on to the low molecular weight heparin, if I may answer that.
So that's okay. That's people are entitled. So
because that's expensive and it has a lot of side effects.
Actually, later on, the patient turns up and says, "Why? If there was something to be done, why not?"
Yeah, we are all.
So the follow-up question on that from Dr. Indu Chauhan is: without any definite diagnosis, if you do start LMWH, when do you stop that? Anybody who wants to take this question?
I don't start it.
So Nidhi is clear. She doesn't start it. Dr. Basho?
So I think, are you starting it in the pregnancy, for the pregnancy?
Yep.
Yes.
At the end. So you'll have to go continuously throughout. Because there are some people who say you do it alternative days or do it something else. That's not right. I mean, if you're really doing it, if you believe in it, then it has to go till the end. There's no point of stopping in between. If you stop it in between, possibly it was never required and you just have crossed the time when you think that things will be all right. So there's no point of stopping it in between. If you want to go, it goes on till delivery. And otherwise, you can stop it anytime. There's no guideline about when to stop it.
And you did cover this question, but just for the benefit of the listener, Dr. Sheikh Zinnat Nasreen, what is your ideal dose of aspirin, as a lot of doses are being recommended?
So 75 micrograms is the dose which has been classically and traditionally been used. The recent studies about the 150 micrograms is mainly for prevention of hypertensive disorders of pregnancy, which we used to call preeclampsia before. So where there have been trials where there are very clear trials about 150 microgram being more effective than the 75 microgram and being used more in a preventive role. So even for an FGR, for fetal growth restriction, we're talking about 150 micrograms. But in a large majority of low dose aspirin, which we use in a variety of obstetric indications, so in that cases 75 micrograms still remains. The NICE guidelines in this regard has very nice table which is quite elaborate on who are the people can.
Hello. I think we've lost Bashubda, is it? Hello? I think as it is, we were coming to the close of this session. So I would like to thank all my panelists here. Also, people at Bharat Serum and Science Integra for hosting us for the second time. We'll also request all our viewers to tune in for the next session on next Saturday. We are going to talk about ovarian stimulation, which is always a matter of interest to most of the people. And at the same time, I'd like to leave all of you with this document by Eshre, where they have covered recurrent pregnancy loss in quite some details. And these are the recommendations that they have posted out. So it's a very nice and easy read and can help to sort out a lot of your doubts and discomforts regarding counseling and handling of recurrent pregnancy losses. Thank you again, all my panelists.
Rohit, on behalf of the panelists, let me thank you for guiding us through and trying to get some nice discussion. Thank you.
It was a really nice discussion, Dr. Bashab. Thank you for being there. Then Dr. Nidhi, Dr.
Thank you, Dr. Nidhi. Thank you, Dr. Simi. Thank you, Dr. Dipanjana.
Thank you, Dr. Bashab.
Bye.